Well, first, I just want to thank the FII Institute for having me and giving me the honor of moderating what will be the best program and panel for the day. Do you guys agree?
Obviously.
No pressure. No pressure.
It's the moderator, really.
So I am so privileged to be talking to you about moving beyond the pandemic. Perhaps the only silver lining of COVID-19 were the innovations and accelerations of those that have happened in the past few years. So my first question is for you, Paul. How do you think healthcare has been revolutionized in the past few years?
So, Geeta, thanks for the question and thanks for having me. So if you think about the pandemic, I think we have a lot of lessons to learn. Lesson number one, I think, is that the generation and analysis of data is key for us to take care of our populations. If you think at the beginning of the pandemic, we didn't have a lot of data, and it really inhibited our ability to follow the pandemic, and this is just the first of many infectious diseases we're going to see. So I think generation analysis of data is essential. Two, infectious diseases do not adhere to the geopolitical lines that we have generated around the world, and that we have to understand at some level we are one global world, and we have to deal with it. I think that's lesson two. Lesson three is that we have huge discrepancies in the baseline health and the accessibility of health care around the globe and within a given country. And that impacts how we can respond to the huge healthcare challenges we have around the world. I think you could begin with those, and then you think about the challenges that I think will move us forward. I think, healthcare can change a lot quicker than we ever thought it could. Right? I mean, we went from, at Hopkins, we had 36 virtual visits a week to 100,000 a week, within a month. So I think we can move much quicker than we ever thought we could in changing the care we provided. I think that's key. I think this whole idea that we can provide care virtually and we don't have to be in front of the patient every time is something, I know we're going to talk a little bit about that's really been something that we're going to move forward in. And finally, I think we were able to generate very effective novel therapeutics in a year. I mean, it's really amazing how science really impacted this pandemic. It took 10 years to identify the HIV virus and know what it was and find a drug for it. 10 years. It took us a year. It took us 3 weeks to know this virus and a year to get a therapeutic. And that's because of investments in basic science made around the globe over the past couple of decades. And I think now as we approach further challenges in healthcare, the platforms that we've developed, be it mRNA or others, will really change the health of the world going forward.
That's such an optimistic outlook. We appreciate that as the kickstart. So Peggy and Mehmood, my next question is for you. Is with that table setting, what are the implications for the future? And love your perspective first, Peggy, with all your work at Magic Leap.
Right, thank you, Geeta, and thanks to the FII for having all of us. I think one of the things that the pandemic taught us is how to operate in a constrained world. And then some of those innovations that happen so quickly, like the vaccine, are continuing forward in a less constrained world. And in my field, we make augmented reality headsets. So quickly, that looks like goggles you put on your eyes. You still see your physical world, and we can put digital content intelligently in that physical world. So during the pandemic, things like surgical procedures had to continue in emergency situations, and we were involved with one where they were training a 30-person surgical team to separate some conjoined twins. And so they had to do this somehow remotely, and they all put on the Magic Leap glasses wherever they were, and they all had the scan of the brain in front of them. They looked at, it was the same model in front of them. They were able to map the surgical pathways. They were able to do some training. They were able to recreate what was going to happen in the operating room. And that kind of innovation occurred because of the constraint, but it goes on today. So we'll continue to be able to train new students this way, even if they're not all in the same room at the same time.
So just to clarify, Peggy is really here. She's not beaming in. That is.
I'm actually here today.
Mehmood, would you like to comment?
Look, I think the amazing learnings that you just heard about during the pandemic also re-emphasized a few things. One, government, in particular the US government, had invested 10 years of science that enabled in 12 months for the vaccine to be produced. And everybody talks about how quickly we produced the vaccine. Let's not overlook the decade of investment that enabled that. And so that has reaffirmed the need for a whole-of-society approach. It's not an industry approach, it's not a government approach, it was that collaboration. The second is the vast majority of the deaths and morbidity from the pandemic were older people and people with compromised immune systems and disability. The reality of it is the significant majority of healthcare costs in the developed world already, which we all know as practitioners, are people over the age of 60 or those with chronic disease. If we do not start to invest in understanding those chronic diseases on a fundamental basis, and from my perspective, the aging process, then the next pandemic or any other is not going to be able to address, because that mortality occurs there. And let's not forget that something like the flu vaccine is only about 40% effective in people over 60. So even having a vaccine doesn't help the majority of people in the category where they probably need them most. There's a lot of learnings there that now point us in the direction of what we need to do moving forward.
Excellent points. So Matthew and Frank, you're up next. As we think about where medicine should go and needs to go, what areas do you see rapidly evolving over the next few years? And I saw Frank point at you, I think because of your yellow shoes. Maybe you start, Matthew.
Thanks. Just a couple quick notes. One is the whole reason I got into virtual reality and what we're doing is we're creating an entire new category of medicine based on this was because of the work that Magic Leap was doing. And my wife happened to be on a plane and sat next to the chief marketing officer at the time, and he regales her the story of AR, VR, and how it's going to change the world. And that was in 2014, right? So she comes back and she fires me up with this whole thing. I go and I look and I realize that there was 30 years of clinical and academic history behind VR, addressing a wide variety of disease conditions, ranging from schizophrenia to depression, anxiety, PTSD, and pain. And for us, and once I recognized the depth of research that was there, and it was only the technology that was limiting us from taking it out of the laboratory, and I knew that was only a matter of time. Now we're at a stage where we can actually harness and unleash the power of VR, and I'll throw AR in there, we call it immersive therapeutics, to actually to treat these complex chronic disease conditions like what we're doing in chronic pain. And we're just at the cusp of this. It's going to be like the Cambrian explosion is what we call this, where we are right now, as we start to get the headsets out there. And in our case, we're the first and only company to get FDA approval as a Class 2 device. And we're treating it as a medical device in terms of how we're taking it to market. And we're getting CMS to back us, which is always a challenge you have around any time you're bringing something novel to the marketplace. So we think the area of VR and AR is going to be a massive transformational power for home health, mental health, digital health. And then the other one, obviously, is everyone's talking about what the world of AI is going to bring. And that one is we're just starting to touch the surface of what we can do with it. And we're super excited for the potential of that.
Thank you. And Peggy did not plant that for anyone curious out there. Frank, tell us your perspective.
Well, from an orthopedic surgical standpoint, I think a lot of what you've heard thus far is that many of these initiatives had started 10 to 20 years ago, and the pandemic accelerated it all. So if we think about medical education alone and surgical training, particularly with remote learning during the pandemic, we had to really step it up, and we've done that. So virtual reality for medical students, residents, and fellows in orthopedic surgery now takes place outside of the operating room. All of their preclinical training takes place in that setting, and it really allows them to really hit the road running when they get to the operating room, which is very important. On the preoperative and intraoperative aspects, it's really extended reality or mixed reality, and that, with the help of giants in the field like the ones sitting on this panel, has really allowed us to preoperatively assess, for example, with joint replacement surgery, where the proximal or the upper tibia is cut and the lower femur, thigh bone, lower leg bone are cut, those cuts are strategically important to really provide the patient with the best outcomes. And if there's a minor variation, that can have an impact on the outcome. So augmented and extended reality allow us to really map that out preoperatively and then intraoperatively use imaging while we're performing the surgery. So that's the second part. The third part I would say is IoT has been huge in my field, which is sports medicine. So we can now look at patients, athletes, pre-injury to try and address this. This is particularly important in adolescents and the skeletally immature, to really see how their bodies move in space around the potential knee injury that might happen and really work on rehabilitation before they actually get injured using wearable technology. In my early career, I was involved in what's called motion analysis or gait analysis, and that was a very invasive maneuver where we had to use electromyography, motion analysis cameras, and now with wearable technologies, we can actually move forward on the pre-injury component. You're now seeing in leagues like Major League Baseball and the NFL, actually wearable technologies used to try and determine when an athlete might tear their ulnar collateral ligament and require Tommy John surgery, or have a concussion in the NFL. So now there's helmet technology, mouthpiece technology, where we can determine how many head hits the athlete gets, what the velocity of the hit is, and when to remove them before there's any clinical evidence that they've actually injured themselves. And then on the post-op rehabilitation phase, the same thing. Now we can manage patients who've had an ACL reconstruction or shoulder dislocation and determine when they can return to sport. Historically, orthopedists essentially were very concrete about this. You're 6 months post-op, you're good to go. We know now that it's not about chronology. It could be 6 months, 9 months, it could be 12 months, particularly in that developmental group of adolescent athletes, to really return them to sports safely before they have a major injury.
Thank you, Frank. Thank you. Mehmood, I want to come back to you for a moment. So if I had to summarize your comments, I think what I heard you say was that 60 is the new 40, right? Everyone wants to live longer. Everyone is living longer. But the question is, how do we live better?
So we're very interested in this whole concept of health span, right? Very quickly, we look at the last 50 years, life expectancy has gone from about 50-something in the developed world to 80. Unfortunately, that 30 years came at a price, 20 years of disability and chronic disease. So we made a lot more progress extending life, but not keeping us healthy. So the question really comes back to how. If we think about how medicine, when we were being trained, we talked about diseases of organ systems. At a molecular cellular level, we're starting to understand that there are common pathways that drive disease process in different organs and different tissues, but those common pathways are very frequently common to cancer, diabetes, cardiovascular disease, fibrosis in the lung, fibrosis in the joints. And so as we start to understand this, we're starting to now understand how to target those, how to measure those pathways, how to target those pathways so that before you get to the end stage of disease, which often is fibrosis in many organ systems, how do you actually prevent that from continuing and ideally, for those who already have it, reverse it. So there's a lot of work now, in particular the last 10 years that this has happened, and we're now starting to actually show, certainly in animals and early stage in humans, the ability to slow it down and even reverse it.
So I want to wrap us today with having everyone comment very briefly on what's stopping us. I mean, you've painted a beautiful vision of how 60 is the new 40, of how we can be in places when we're not physically there, of how we can better manage pain, how we can think about therapeutics differently. But what is actually stopping us, and how do we get there? And maybe you can kick us off.
So I'm going to be the optimist. And, I actually think if you think about how you develop drugs, and I think Mehmood's exactly right, we now have this much better understanding of human disease. In the past, we were limited by the fact that most drugs were small molecules and that only certain targets could be druggable, as we would say. In today's world, between RNA, antisense RNA, other inhibitory type of nucleotides, cell-based therapy, antibody therapies, the ability to target almost any molecule in the cell has never been there before. So I actually think it's going to be the golden age of drug development as we go forward. What people don't understand is that mortality in the U.S. from cancer has decreased by 33% over the last 20 years. We're going to see that same advancement in the next 5 or 6 years with the new cancer therapies, and with the help of things like health evolution, you're going to see those same pathways really rapidly targeted. I think we're going to have a healthy aging coming very quickly. So I'm actually optimistic.
Well, let me give, one is courageous leadership. Are we willing to make the investment and policy decisions it's going to take to create the right incentives? We're talking about slowing and preventing disease rather than episodic care. That requires a whole new way of thinking about healthcare. The second is regulatory reform. Today, there are very few drugs approved or treatments approved to prevent disease. Vast majority are about treating disease. How do we come about that? The third is scale and democratizing technology. We cannot continue to progress with fewer and fewer people being able to afford the cutting-edge technologies and the vast majority of the world's population left behind. Imagine a world where healthy aging is possible, but it comes at a price that most of the world can't afford. So it's very much about bringing everybody along into this. And finally, where's the investment going to come across sectors so that we can do this in a cross-sector, whole-of-society approach?
Peggy, go ahead.
Well, in our field today, augmented reality does have many use cases for healthcare. Going forward and talk about hitting more of the masses and having a lower cost device, that's really where we want to go. We want to have a device that looks like your glasses. You put these lightweight glasses on, they're low cost, and everybody can have that same capability. So the patient at home can have that capability without having to come into the doctor's office. But that's going to take, very similar to the mobile phone, where they were big when they first came out, and then they got very small. We have to do more silicon integration. We've got to get smaller batteries. The whole form factor has to get small, light, like these glasses. That will hit all of the masses at a price point that people can afford, and that, I think, will be yet another game changer.
Frank, go ahead.
So I would say that three of the six of us here on the panel have taken care of patients and people with musculoskeletal disorders over the course of our careers. And if you look at the last 50 to 60 years, most public and private investment in industrialized nations has gone towards the high mortality diseases, appropriately so: cardiovascular health, stroke, diabetes, hypertension, COPD. And in the developing countries, it's been mostly towards childhood mortality and infectious disease. These are all critically important issues. I would put a plug in for musculoskeletal disorders because, at least in the United States, most visits to medical care facilities are related to MSK health. And if you look at the global disease burden, it affects everyone: children, adolescents, young adults, middle-aged adults in the prime of their career, and of course the elderly. And it's very clear that a declining musculoskeletal health leads to declining mental health, cognitive abilities, and it goes across all societies: industrial societies, subsistence societies, and indigenous societies. So I would put in a plea in for public and private funding for musculoskeletal disorders.
I think that's why they have a rheumatologist moderating the panel, so I second that one. And Matthew, last but not least.
Yeah, so on the MSK front, we absolutely completely agree with you. And one nice thing about, from a pain perspective, right, it's that with chronic low back pain, it's one of the biggest disease conditions in the world, right? 100 million suffers in the U.S. I think it's like 65 million would be chronic low back pain and MSK here, and we spend hundreds of billions of dollars trying to address it. So the fact that we're actually starting to understand that it is this biopsychosocial condition that's not just about the physiology of the pain, right, but about the comorbidities of depression, anxiety, catastrophization, sleeplessness, et cetera. I think we're starting to get to that point where we can take different approaches to it than just simply trying to take using a pharmacological approach or an invasive approach. So for us, when we think about what it takes to bring a novel device or therapy to the marketplace that's not a pharmaceutical, one, you got to have that massive body of data that demonstrates that this actually can work, right? Because you got to change the doctor's perceptions around what they've been doing traditionally to say that something new should be used. That's a piece of the equation, but I think it's a small piece. The other one is, in the world of digital health or digital therapeutics, it's a policy question. Because this idea of a digital pill didn't exist back when CMS was created. And so if we want to actually bring reimbursement for the digital therapeutic space, the fact we can use a cell phone as an example to help someone, or some of the stuff that what we're doing, that you can use a different type of device to achieve it, you've got to go and you've got to get a policy change that will actually create a reimbursement pathway for a new type of treatment. We're fortunate we can actually use our device to tap into pre-existing pathways, and we're fortunate we just got the CMS to give us unique codes, so we're excited by that. But I think about broader for the space as a whole, what we need to do, and that's one of them.
Well, thank you for wrapping us. Officially, best panel of the program. I think you all agree. Thank you all so much for joining us.
Thank you, Geeta.
Thank you.
Thank you, Gita.